Okay, so now I'm going to turn to medication treatment for insomnia, because the reality is not every child is going to respond to behavioral techniques, or even though we write best used after behavioral treatments have been tried unsuccessfully and in combination with behavioral therapies, there are families, like the family I gave you the example of earlier, who are too overwhelmed, who are not in a position that they can implement the behavioral. And the reality is we do use medications. We try to use them with these guidelines that I'm about to go over. And we, as quickly as possible, try to implement the behavioral techniques. But there are families in crisis who need this. And whenever possible, we try to use a medication that will treat a coexisting condition or a comorbidity. So if it's a child with epilepsy, I'll try to use a medication they're already using, maybe at a slightly higher dose, or I'll move it from the morning to the evening. If it's sedating, I might add an evening dose. And then if it's anxiety or mood disorder, I'll try to choose a medicine, oftentimes in conjunction with a psychiatrist, to help. And that way you're treating two things rather than one. And the other point I should make here is there definitely is a role for using medications to treat comorbidities that affect sleep. So for example, if the child is anxious, I've even found that a stimulating antidepressant given in the morning can improve sleep at night, because the medicine is treating the anxiety, which is then helping the child fall asleep better if they're not anxious. So I think it's important to realize sometimes we use these medicines for the underlying condition, and that's totally appropriate. Sometimes we'll use a medicine for both. We'll use a medicine to treat an underlying condition and also help with sleep. And then a good example of that might be a sedating antidepressant given at night that would help both sleep and depression. We like to start at low doses, especially in children with developmental disorders, because they're less able to communicate adverse effects to us, and that they may not be able to communicate adverse effects at all. So we want to make sure we start low and go slow. And then it's worth mentioning that for primary insomnia, there are no Food and Drug Administration approved drugs. It's all what we call over-the-counter. We published on 107 kids with melatonin. This was the largest retrospective review, meaning going back and looking at what had been done clinically to date. And we published that in 2008. And we only had 3 out of 107 kids who had side effects. And the side effects consisted of grogginess, feeling kind of spacey in the morning, and increased bedwetting, which might not have actually have been, it might have been that they were sleeping more and they were only wetting their bed when they were asleep, and the melatonin was helping them sleep more. So we were really pleased with how melatonin did. And as I mentioned earlier, melatonin is generally safe. You just have to be sure the preparation you buy has melatonin in it and not something else, and that it's not going to interact with any other medicines, and that you're not going to miss a medical disorder. And then the other medicine I wanted to mention that we were very successful in using was gabapentin, which we published on last year in kids with autism who did not respond to melatonin for night waking. So they might have been falling asleep okay on melatonin, but then they were waking up. And what's nice about gabapentin, which is also called Neurontin, is that it actually has been shown to increase the deep sleep stage. N3 sleep is what we call it, deep sleep, delta sleep. And it also has very few side effects. It has more side effects than melatonin, in that kids can get sometimes a paradoxical reaction where they get more irritable and have more trouble sleeping. We also sometimes see this with Benadryl. When we experienced this in our trial and we stopped it right away, the side effect went away too. And then the other neat thing about the gabapentin is that it's one of the medicines that's used for restless legs. So if we can't make a diagnosis of restless legs, we can consider using gabapentin to help both restless legs, periodic leg movements of sleep, and insomnia. I also wanted to mention there is an extended release preparation of melatonin that's under study. The challenge with melatonin, its half-life is really short, meaning how long it's in the system, and the duration of action has been said to be only about an hour. Now, with that said, sometimes all you need is to get the child to fall asleep, and then they're asleep all night. But many parents have been concerned that they'll give melatonin, their child will sleep for a few hours, but then they'll wake up. And that may be because melatonin is not necessarily treating the night wakings. It's only in the system long enough for the child to fall asleep. So you might be able to get the child to stay asleep because you're teaching them to fall asleep with the melatonin, you're doing your behavioral techniques. The behavioral techniques are reinforcing the calming activity and the hypnotic activity of the melatonin. But there are kids out there who are going to wake up, and the melatonin in its immediate release form, which is most of the melatonin that's available in North America, is not going to keep them asleep. One of the challenges with extended release or timed release melatonin, as with any extended release or time release prep, is the way that extended release or time release works is there has to be a coating around the medicine. It has to be an actual pill. You can't crush it. It's not liquid. You actually have to take this pill, and to get the time or extended release property of the pill. The challenge is that many of our kids with autism can't swallow pills because of their tactile sensitivities and other things. So we have not been able to successfully test or try out whether extended release melatonin works in these kids who have night wakings. There's a study underway in Israel. Well, actually, it's in this country. It's in the U.S. with a company from Israel called Neuram Pharmaceuticals, and they have a microtablet, which is a very tiny preparation of melatonin. It's about 3 millimeters. It's about the size of a cake sprinkle, and it's easier for kids with autism to swallow. So it will be interesting to see if that has any utility over the immediate release melatonin in terms of night wakings. Other than that, the options are pretty much a grab bag. There's clonidine, there's mirtazapine, nioprasine, zolpidem, zalopram, ramelteon, and risperidone. And none of these have been tested in definitive trials. Many of them have side effects, and many children, as I mentioned earlier, will come to my clinic on multiple of these agents. And it's tricky to try to figure out what to do. Oftentimes, what I end up doing is actually lowering the medication if I can, because what I'll see, and this will come to us in this afternoon when we discuss it, is children will be so over-medicated and so sedated that they've not learned how to fall asleep on their own. So they wake up. It's almost like they wake up a few hours later with a night waking because they've not learned to soothe themselves back to sleep. But while if they're on less medicine, they'll actually be sedated enough to be able to fall asleep with the behavioral techniques we teach them. And then they can get back to sleep on their own in the middle of the night. So oftentimes less is more. And what we'll do is we'll try to whittle away at some of these medicines over time to see if we can get a better effect. But what unfortunately, like Osmond's example, it's not unusual to see layering where a child is not sleeping, they get started on meds, then they get put on more meds, they get put on still more meds because they're hyperactive during the day from not sleeping, and the sleeping meds haven't helped them, and then they get put more on sleeping meds, and they end up as the example he provided with 7 different medicines that they're on. And then I'm just going to reinforce, and we'll talk about this afternoon, why we want to really think about educational behavioral interventions first, after excluding these medical contributors, these medication, medical, sleep difficulties, night terrors, sleep apnea. And it's because of the challenges understanding expectations about sleep, being there, and the challenges with transitions, emotional regulation, all being amenable to behavioral sleep education, the not being able to communicate adverse effects of medications, and finally that there's limited evidence for medications to treat insomnia and autism. However, if the behavioral approach does not appear feasible or the intensity of symptoms has reached a crisis point for the family, we consider medications. So going back to the practice pathway I showed you earlier, hopefully you could see where things are starting to fit together. We do our screening, and then in terms of the treatment, oh good, so you can look at this in a bigger copy. Thank you, Deborah, for blowing that up. So the part that we've been talking about in the last few minutes has been this initiating and this middle section, looking for the medical contributors, the sleep apnea, the night terrors, the seizures, and then either having the pediatrician or other primary healthcare provider initiate evaluation and treatment, or making a referral. So in some cases, like a GI problem or eczema, the medical condition can be treated and solved at the level of the primary practitioner. In other ones, like epilepsy or sleep apnea, it oftentimes requires a referral to the subspecialist, like the neurology subspecialist or the sleep subspecialist. And then at the same time, we're doing the assessing if the family is able and willing to use the educational approach, initiating the sleep education program, which could be one of the toolkits that we've given you today, or something more intensive, which we'll talk about this afternoon. And then if the family is unwilling or unable to use the educational approach, if they're in a state of crisis, they're just not able to do the behavioral, we will then move on to consultation with the sleep specialist.